My name is Joseph Muller. I'm a primary care and addiction medicine doctor working in Washington, D.C. We will answer the following questions during this video. What is alcohol withdrawal? Who gets it? And how do we screen for it in jails? Let's briefly review alcohol withdrawal. More than 50% of people with alcohol use disorder will have some symptoms of an alcohol withdrawal syndrome, but most will only have mild withdrawal. Those symptoms can include anxiety or irritability, insomnia, headaches, tremors. They'll usually peak within the first 24 hours and subside over a few days. But what about people with more than mild symptoms? We assess the severity of withdrawal using validated scoring systems like SIWA that we'll discuss shortly. Complicated withdrawal involves both severe symptoms of withdrawal as well as either seizures or alcohol delirium. Now, alcohol withdrawal seizures typically occur 6 to 48 hours after the last drink, and they may present before other symptoms of withdrawal. They're usually a single generalized tonic-clonic seizure, and if untreated at that point, they often will progress to delirium tremens. Who gets alcohol withdrawal? Generally, you need to drink at least 4 drinks at a sitting, at least 3 days a week for a month. Some sources say higher amounts, like 6 to 8 drinks a day. Alcohol withdrawal, though, can develop within 6 hours after the last drink. Screening for substance use withdrawal, including alcohol, is very time sensitive when someone gets incarcerated. If the patient already appears unwell to a layperson, if they have heavy drinking, so more than 4 days a week of drinking and 8 standard drinks a day for men or 4 for women, or a history of complicated withdrawal. Now, for other patients, they still need to be monitored for withdrawal, but they might not have to be immediate. So people who reported that they've had withdrawal in the past, or people who report greater than 4 days a week of alcohol use, but below the threshold for immediate assessment. How do we determine who is at risk of severe withdrawal? Patients are at low risk if they have not had any symptoms for 48 hours after their last drink. But how do we risk stratify further? In addition to the frequency, the amount of alcohol consumption, and their last drink, we need to ask about a history of complicated withdrawal, if they've had multiple prior episodes of withdrawal, if they've had a long duration of heavy and regular alcohol use, and then some questions about their current withdrawal symptoms. Are they having marked autonomic instability early on in the course? Did they present with a seizure? Are they withdrawing from other substances like benzodiazepines? And then what other health conditions do they have? Are they older, and do they have comorbid illnesses? Some key comorbid illnesses to think about include pregnancy, epilepsy, cirrhosis, unrevascularized coronary artery disease, and really any condition that affects their ability to tolerate PO medications. Notably, even for patients who don't have symptoms of alcohol withdrawal yet, if they are at high risk of developing severe alcohol withdrawal, prophylactic treatment may be appropriate. So how do we assess the severity of alcohol withdrawal syndrome? I'm going to briefly compare 2 tools, the BAWS, or Brief Alcohol Withdrawal Scale, and the SIWA-AR. I want to note, though, these are not diagnostic tools. They are tools for evaluating severity. You cannot reliably exclude alcohol withdrawal just based on these scales if you haven't looked at the time since their last drink, and you have to also consider if they have other substance withdrawal syndromes at the same time that may show up as higher scores on the BAWS or the SIWA. Alcohol withdrawal and opioid or other substance withdrawal often occur at the same time in the same patient and need to each be treated appropriately. Now, once we've determined that a patient has alcohol withdrawal, we need to determine what the best treatment setting. It's important to remember that we can't just assess their symptoms at one point in time. We need to try to predict the projected course of their withdrawal. What are the facility considerations in what the appropriate level of care is? In your facility, how frequently can a patient be monitored? Can they get vital signs done? Can they get structured withdrawal scales? Staff well-trained in administering whatever withdrawal scale you choose have to be available at all times for treating alcohol withdrawal. What's the availability of timely appropriate medication? What's the clinician availability to review these alcohol withdrawal scales and other assessments? Finally, we need to consider the patient's trajectory. What are their current signs and symptoms? What are their comorbid conditions? And what is their risk based on their history of developing severe or complicated withdrawal? Once we've identified a patient's alcohol withdrawal, and assessed its severity, we have to start treating it. Benzodiazepines are often the mainstay for treatment of alcohol withdrawal outside of hospital settings. There are two main varieties of benzodiazepine protocols for treating alcohol withdrawal: symptom-triggered protocols or fixed-dose protocols. Symptom-triggered protocols have the advantage of minimizing the overall medication patients receive and the duration of treatment, but they require more intensive regular assessment by trained staff. Fixed-dose protocols have set doses that are administered at regular intervals that taper over time in dose and frequency. While fixed dosing is easy to administer, regular monitoring is still required because underdosing may lead to poor symptom control or progression of withdrawal, and overdosing may lead to sedation. So you need to still be evaluating patients at least every 8 hours. Note that for patients who have a history of particularly heavy alcohol use or rapid onset of symptoms, some protocols will increase their starting doses. For example, diazepam 20 milligrams as an initial dose. But which benzodiazepine should we choose? Traditionally, long-acting orals like chlordiazepoxide or diazepam have been favored. Diazepam and lorazepam offer the advantage of a faster onset, though. It's important to consider liver metabolism in patients who either have a known diagnosis of cirrhosis or, based on your exam, have a high risk for it. So, for example, lorazepam is both an oral or an intramuscular option that is not hepatically cleared. What are some other assessments and supportive care that go into treating alcohol withdrawal? As a reminder, we should treat other concomitant withdrawal syndromes. You should still start opioid agonists for opioid withdrawal when indicated at the same time as benzodiazepines for alcohol withdrawal, though those patients may need more frequent monitoring than patients with alcohol withdrawal alone. Hydration is a really important consideration because dehydration can occur in the setting of alcohol withdrawal or nausea or vomiting. Consider checking electrolytes, as derangements are also common in alcohol withdrawal. People with heavy alcohol use may have vitamin deficiencies, so consider starting thiamine supplementation. And some other elements of supportive care include minimizing environmental stimulation and avoiding isolation. It's particularly important to assess anyone who's presenting with a withdrawal syndrome for suicidality, because substance withdrawal can worsen suicidality, which is one of the highest risk conditions on incarceration. Now, we've talked about assessment, we've talked about pharmacotherapy and other aspects of treatment. What are signs that your treatment is not working? Up front, if a patient has severe withdrawal or complicated withdrawal, they should probably be transferred to a hospital level of care. Now, anyone whose symptoms are progressing despite the initiation of treatment should also be considered for a referral to a higher level of care. And also, patients who have other medical conditions or psychiatric conditions that are worsening at the same time, for example, suicidal ideation, may need to go to the hospital. And finally, either unstable vital signs because of inadequately treated withdrawal or severe or ongoing oversedation as a side effect of treatment. So to summarize what we've talked about, early identification and prompt treatment of alcohol withdrawal in jails is key. There are validated withdrawal assessment tools, as well as key history questions that can help determine the appropriate level of care. Benzodiazepine-based medication options include fixed dose protocols or symptom-triggered protocols. And regardless, it's important to monitor their response to treatment. Finally, after you've gotten the patient through their withdrawal period, it's important to facilitate ongoing treatment for their alcohol use disorder. Thank you.